Welcome to the session on hyperthyroidism. So previously we covered the physiology of thyroid gland and the thyroid hormones that it produces. Today we'll talk a bit about the pathologies that surround the thyroid gland. So we'll start off with a little bit about the general terms that we're going to be using. So hyperthyroidism is going to be excessive concentration of thyroid hormones. So why is there going to be high levels of thyroid hormones? One reason is the thyroid itself could be producing a lot more, and diseases associated with this are Graves' disease, toxic multinodular goiter, toxic adenoma. Another cause is that maybe there is an excessive release of preformed thyroid hormones. So thyroid hormones are already kind of formed and ready, and something activates it and allows it to be released before it's meant to be. So in thyroiditis. Or maybe there is an endogenous or exogenous extra thyroid source. So maybe somewhere else in the body, something's producing thyroid hormones, or maybe through medication. And we'll talk more detail about all these causes. So we'll start off with primary hyperthyroidism. So this is elevated thyroid hormone due to autonomous production by the thyroid. So thyroid itself is the one that's causing the hyperthyroidism, and it's producing a lot. Therefore, the pituitary gland, through the negative feedback, we're going to have low TSH because we don't want to stimulate the thyroid to keep producing. Secondary hyperthyroidism is when the thyroid itself is normal, but it's a TSH that's elevated. So there's something above that's happening, telling the thyroid to say, hey, we need to increase the thyroid hormones when we don't really need to. So it's a TSH that's the issue. We're going to have elevated TSH and elevated T3 and T4. So clinical manifestations. So it could range all the way from asymptomatic to a thyroid storm. So an easy way to think about the symptoms is think about how the thyroid hormones influence our body. So T3 and T4 can amplify the catecholamines signaling. So it increases our sympathetic symptoms. So it does this through an increase in the beta adrenergic receptors. So these receptors are very important for our sympathetic nervous system. And what these thyroid hormone does is that it increases the amount of receptors available and thus increases the symptoms of the sympathetic nervous system. So as such, one of the key symptoms are the adrenergic responses. So let's think about what causes our adrenergic responses. So elevated adrenaline. So you're going to have palpitations. You're going to have heat intolerance. Some people might have diaphoresis or sweatiness. They might have a tremor. So think about how you would be in a fight or flight response. Some people can have a hyperthyroid stare or lid lag, and this is due to the sympathetic innervation of the muscle, the levator palpebrae superioris, that lies over here. So here are the two pictures that talk about the hyperthyroid stare and the lid lag. So in the hyperthyroid stare, you can see that the upper eyelid is innervated by this increased sympathetic response and therefore is elevated. And you can see that there is a classic hyperthyroid stare with the presence of sclera that's above and below. So we can see mainly below, but in some of the patients, we can actually see above as well. And this is this classic hyperthyroid stare. The second one is lid lag. So when you ask the patient to look down or straight ahead, you can see that there is the lid retraction. And this is again due to that contraction of that muscle that's innervated by the sympathetic nervous system. And some patients can have increased bowel motions as well. So cardiovascular, you can have tachycardia, and it can actually trigger atrial fibrillation. And this is a concern as well. When atrial fibrillation then develops into heart failure, you can then have symptoms of dyspnea, orthopnea, and peripheral edema. So this heart failure symptoms secondary to this. You can have cutaneous symptoms, so onycholysis in the nails. You can have hyperpigmentation. And there are some classic symptoms of Graves' disease, which we'll talk more detail about. One of them is pretibial myxedema. So here you can see this swelling and elevated patches, that's so lumps and swelling that's noted in the tibial areas. And another one is thyroid acropathy. So you can see the swellings of the digits and clubbing of the nails, which is more evident here. You can see this clubbing. Of course, clubbing is not the only symptoms for thyroid, and it can indicate a whole sorts of conditions, but it's just an indication that this could be a thyroid issue as well. It's a combination of these symptoms. So what causes it? It's important to think about the cause of Graves. So we'll talk more detail in the next slides, but Graves' disease is due to an increase of antibodies against our TSH receptors. Well, these antibodies can actually go and activate other parts in our body. It can activate fibroblasts within our tibial areas and our hands, and increase secretion of glycosaminoglycans, in particular hyaluronic acid. So this causes increased swelling. This production of mucopolysaccharides by the fibroblast activation draws in fluid and causes this appearance. Thyroid is very important for our metabolism. So hypermetabolism, they can have weight loss despite having increased appetite. They can have neuromuscular, they can have brisk peripheral reflexes, and even proximal muscle weakness. They can also experience symptoms of anxiety, insomnia, or psychosis. Ocular symptoms, they can have increased lacrimation and sensitivity, and very characteristic findings for Graves' disease is again very similar to that activation of fibroblasts. It can actually increase edema within the orbital area. So you can have periorbital edema. You can report diplopia, and also exophthalmos, which is bulging of the eyeball itself. And this is more appreciated on the side-on view, where you compare it with the midline eye, and you can see that it is protruding anteriorly. And another word is proptosis as well. So an overview, these are the conditions that can cause hyperthyroidism, and we'll go into more of these in greater detail. So start off with Graves. What is it? It's an autoimmune disorder, and it's caused by thyroid stimulating antibodies against our TSH receptors. So our thyroid gland is coated with TSH receptors. TSH is a very important hormone to activate and encourage thyroid production. When we have antibodies against these receptors, it can actually activate these receptors and trigger thyroid hormone synthesis. It's the most common cause of hyperthyroidism, more common in females, and around 20 to 40 age of onset, and can be associated with a lot of other autoimmune conditions. And this is very common with autoimmune condition. When you have one, you are more likely to get another one. So how do we diagnose it? There are these characteristic symptoms. We want to get a TSH, and if this is abnormal, we'll follow this up with a free T3 and free T4. In terms of our full blood count, we could see normocytic anemia due to the anemia of chronic diseases. We'll get a CMP. We can see hypercalcemia. This is due to the thyroid hormones activating osteoclast in our bones and allow the release of these calcium into the blood. We could get an ECG, and why is that? Well, it's important to monitor for the presence of atrial fibrillation if the patient's got it. We could get thyroid stimulating antibody serology. So this is going to be the one that can indicate whether it's Graves. A radioactive iodine uptake scan is also an important scan. So here we've actually got the radioactive iodine scan. We give the patient radioactive iodine and see the uptake by the gland. So here is a normal gland. Because there is increased activation by TSH receptors, our thyroid is going to be active overall and is going to take up more iodine to increase its production. And that's why we can see a greater iodine intake. All right, next we're going to talk about toxic nodular goiters. What causes toxic nodular goiters? It's thought to be a sequence of events. So you start off with a bit of iodine deficiency, and that results in deficiency of T4 production. Then this induces thyroid hyperplasia. So our thyroid cells are going to increase its cells and induce hyperplasia to form nodules to try to compensate. When this increased replication is occurring, this predisposes these nodules to have a somatic active mutations in their receptors. Once this mutation in this receptor occurs, then these nodules can then start producing excess T3, T4. So it's an abnormality in a compensation process. When we have a single nodule, it's just called a toxic adenoma. When you have multiple nodules, it's called toxic multinodular goiter. Kind of has it in its name. How do we diagnose it again? So we start off with a TSH, and then we follow it up with a free T3 and free T4. Again, we have our normal standard bloods and our ECG. We take our radioactive iodine scan. You can even take a thyroid ultrasound with a Doppler. So here we can have our Graves' disease, as we talked about before. And then you can have a look at this. Here is our thyroid gland, and there is an autonomous nodule. So this is producing excess T3 and T4. And this is the one that's got that mutation in this nodule and therefore responsible for a hyperthyroidism. So this is our toxic adenoma. Here we can see multiple nodules with these mutations, and therefore this is a multinodular goiter. It's important to differentiate between the scans. So the scan's very important because when we palpate the gland and we see it's enlarged and we notice these nodules, we want to differentiate between a hot nodule and a cold nodule. Hot nodule tends to be benign. Cold nodules can be associated with carcinomas and malignancies. So a thyroid ultrasound with a Doppler can also be very important to differentiate these nodules to see the structure of the nodule itself. The Doppler can see increased blood flow to these nodules. So a biopsy guided by ultrasound can then be thought and considered depending on the results of the scan. So we'll start next here's our ultrasound. And you can see there's increased blood flow across the peripheries. And this is a classic nodule in the thyroid gland itself. So thyroiditis, it is an inflammation of the thyroid gland resulting in the release of T3 and T4 into the circulation. So it's already produced, something's inflamed it, and now it's released into the circulation. There are different types of causes. So you got your subacute thyroiditis, you got your lymphocytic thyroiditis. So we'll talk a little bit about each one. So subacute thyroiditis associated with viral infections. So you most likely a fever, you get a viral infection and an inflammation of the thyroid, and that releases its hormones into the circulation. Lymphocytic thyroiditis, so postpartum thyroiditis. So after pregnancy, some patients can get thyroiditis. And what's the cause? During pregnancy, we think of the fetus or the developing baby as a foreign object in a way. And thus, we don't want our body to reject it. It's quite precious. So our body downregulates our immune system. And after the baby is delivered, there is an immune rebound, and therefore antibodies can be produced against the thyroid, causing thyroiditis. There could be autoimmune diseases. It could be drug-induced. So there's a few medications. Lithium can be toxic to the thyroid gland itself. And amiodarone is an interesting one. So there's two types. There's type 1 and type 2. Amiodarone in type 1 is when you've already got a predisposing condition, maybe like Graves, but amiodarone has a very high iodine content. In fact, a 200 milligram amiodarone pill has about 75 milligrams of iodine in it. Therefore, it kind of exacerbates whatever predisposing pathology that's already in that thyroid, resulting in increase thyroid hormone production. So think of amiodarone giving extra iodine to supply whatever it's already going on. Type 2 is due to amiodarone's effects causing inflammation to the thyroid, causing a thyroiditis picture. And this is normally in a normal looking thyroid gland. Hashimoto's thyroiditis is antibodies against thyroid peroxidase. So remember our enzyme that's really important for combining iodine and thyroglobulin, forming our thyroid hormone in the first place. If not, refer back to the physiology of the thyroid gland. But antibodies against that can induce a thyroiditis picture, and you have an initial hyperthyroid picture. Contrast induced, radiation induced. Palpation's an interesting one. So maybe you had a surgery for your parathyroid glands, which sit right behind your thyroid gland. During surgery, you need to manipulate the thyroid gland itself. This manipulation process can actually induce thyroiditis. Symptoms are very similar for each of them. It has symptoms of hyperthyroidism, possibly a goiter. Subacute's quite different, where you actually have pain and tenderness of the thyroid gland itself. How do we diagnose it? Again, very similar sorts of symptoms. Diagnostic test, TSH level, free T3, free T4. We still want to include our serologies to rule out Graves. When we get TPO, those thyroperoxidase antibodies, it can be elevated in certain types, so autoimmune, postpartum, even Hashimoto's, which is not included here, or it could be low in subacute thyroiditis. A radioactive iodine uptake scan is quite important. So here you can see there is an absence of the thyroid gland. Why is that? So in thyroiditis, there is some inflammation that's happening to the thyroid gland, and there's release of these hormones into circulation. So your pituitary gland picks this up and says, we need to turn off our TSH. There is something going on. We don't want to fuel this process. So your TSH is reduced. Therefore, the thyroid gland does not have that stimulation from TSH to take up the iodine. It completely shuts off. So that thyroid doesn't want to produce any more thyroid hormones, and therefore won't take up that extra iodine that you've put for this diagnosis study. In fact, you can actually see your salivary glands taking up, which is actually quite normal, and instead of the thyroid gland itself. So you see a near absent or reduced picture. Less common causes, gestational hyperthyroidism. So usually this is in first trimester of the pregnancy. This is due to beta-HCG, an important hormone in pregnancy, being so similar to TSH. So beta-HCG then stimulates the thyroid gland. Hyperemesis gravidarum is also important pathology during the first trimester, and that's due to that beta-HCG again resembling TSH. Fictitious thyrotoxicosis is when there is ingestion of the thyroid hormones through the medication, so the patient might take more than required. And how do we know if it's medication induced? A very key important factor is, well, when we do our uptake scan, our thyroid's not going to take up extra iodine because it's already too much in the system. And there's going to be low thyroglobulin levels. So remember when we, in our thyroid physiology lecture, when we release our thyroid hormones from our thyroid also releases a byproduct of thyroglobulin, which is actually cleaved off by our lysosomes. And if you don't remember, refer back to that. And because this is a byproduct, there's actually going to be low thyroglobulins because our thyroid is not producing hormones anymore. there's already enough in the circulation from the medication. So our thyroid's not going to make any more by itself. So you're going to have very low levels of these byproduct. There could be a metastases of this follicular thyroid cancer. Stroma ovari is ectopic tissue. So if there's an ovarian tumor, a dermoid tumor, and this has a specific thyroid tissue type, and that secretes hormones itself. And the last one, so these are all quite rare causes, trophoblastic tumors or germ cell tumors. These produce beta-HCG. And again, we know that beta-HCG resembles TSH. All right, now we got to the treatment. How do we treat this? Very important to treat the symptoms because we don't want to get atrial fibrillation and heart failure. So first line is beta blockers. Propranolol is very good for its first line. It's a non-selective beta blocker and can calm the symptoms of hyperthyroidism. Some alternatives, so if there's contraindications, atenolol and metoprolol. So the problem is propranolol is a non-selective beta blocker. Therefore, it can act on beta-1 and beta-2 receptors. Beta-1 receptors are in the heart, beta-2 receptors are in the lung and elsewhere as well. So if someone's got asthma, propranolol is probably going to make it worse because it's going to induce vasoconstriction through the activation of beta-2 receptors. So therefore, if they have stable asthma and mild COPD, and we don't want to exacerbate this with propranolol, we can consider a more selective beta blocker. If there's contraindication of beta blockers overall, you can consider calcium channel blockers. So Raynaud's phenomenon is also another one that we should be careful of. So this is when, as you can see your hands here, it's vasoconstriction of the blood supply to the peripheries due to, and it's exacerbated by cold, stress, or emotional stimuli. And therefore, if we want to avoid these symptoms, selecting selective beta blockers might be important, or even considering calcium channel blockers. All right, so what about definitive management? We want to get on top of this hyperthyroidism. First one is anti-thyroid medications. Another one is radioactive iodine ablation. Sorry, that should say medications. And then third one is thyroid surgery. So let's go into more detail. Anti-thyroid medications. So 20 to 75% of Graves' patients achieve permanent control with this in 1 to 2 years. So very important to note that. It can be used in thyroid storm, Graves' disease, or contraindicated in the other methods of definitive management. So there are 3 main types as methylmazole, carbimazole, and PTU, so propylthiouracil. How this works is it inhibits TPO. So remember TPO, thioperoxidase. It combines our iodine and our thyroglobulin and forms our precursors for T3 and T4, which will be released into the blood. So if we inhibit this process, great, we're going to have less thyroid hormone production. PTU has an additional advantage because it also blocks the peripheral. So it inhibits 5-deiodinase. So you can see that it inhibits T4 to T3 conversions. T3, as we know, is our more active biological hormone, and therefore it prevents this conversion. So it's very useful in thyroid storm and first trimester of pregnancy. So usually we start off with this one, methylmazole, and that's because PTU has a higher risk of liver injury and hepatitis. So we usually start with carbimazole or this one. So important side effects is that we should be monitoring for agranulocytosis. So these can actually cause a syndrome called agranulocytosis, and it's important to measure the full blood count of the patient over a period of time and monitor for this complication. But the one of the main reasons why we switch to PTU is because in first trimester pregnancy, we know that these two are more associated with birth defects, and therefore we switch to PTU. And after that first trimester of pregnancy, where that crucial structures of the baby is formed, we can switch back to the other two. Second option of method. So talk about anti-thyroid drugs. Second one is iodine ablation. How it works is it induces destruction of the thyroid tissue. Very good in thyroid adenomas and nodulars, multinodular goiters. Why is this? Because our multinodular or toxic nodules are secreting these thyroid hormones. They're the more active ones. They're going to take up this iodine, and they're the ones that are going to be destroyed. If we fail with anti-thyroid drugs and Graves' disease, or if they're a high surgical risk patient, this is a good option as well. We don't want to do this in pregnancy, breastfeeding, or children. It's radioactive. And we don't want to do it in Graves' ophthalmopathy. And that's because it can actually worsen symptoms of exophthalmos and orbital swelling. So complications, most of the Graves' disease patients will be rendered hyperthyroid and will need lifelong replacements. It can cause secondary malignancy and leukemia because it's radioactive. And it can cause inflammation of the salivary glands because salivary glands can also take up this iodine. Last thing is thyroid surgery. When do we do this? Well, there are two types of thyroid surgeries. You can, in Graves' disease or toxic multinodular, where the whole gland is affected, we can consider a near total or a total thyroidectomy. When there is only just a nodule, like a toxic adenoma, we can just consider removing a lobe. We don't want to do this if there are severe comorbidities that's rendering the patient as higher risk for surgery. We don't want to do this in pregnancy as well. And when do we do this? When the goiter or the neck lump is so large that it's causing obstructive symptoms, or so when we're having dyspnea or stridor, we're worried there's compression of the trachea. If there's hoarseness, we're worried about compression of the recurrent laryngeal nerve. When there is dysphagia, we're worried about compression of the esophagus. So if there's failure or contraindication of other methods, which makes sense, and if there's concomitant hyperparathyroidism. So if our parathyroid glands are also having issues, we can perform a thyroidectomy and remove these as well. So it's a more greater indication for thyroid surgery. Common complication is hypoparathyroidism, which makes sense because they lie right behind the thyroid gland. So when we're performing thyroid surgery, we can injure or impair these functions. These tend to usually be transient, but it's important to monitor recovery of these glands as well. So that concludes a session of hyperthyroidism. We're probably going to have another session on hypothyroidism. And yeah, please like and subscribe and comment down on any further topics. And I'll see you next time. All right, bye now.